شاء الله. ميرسي جدا على الانفيتيشن، وانا دايما ببقى تحت امر حضرتك لما يبقى في اي كونفرنس اي ويبينار. I will start by sharing my screen. So for the presentation, then I will do full screen. Okay, so let's start. Overviews will be introduction about what I do, then why to write a book, what about the book, then there's a concept called intelligent automation, which I would like to introduce it first. Mixed reality is a part of a big picture, and it's only one part of the whole thing. So I would like to introduce you to the concept of intelligent automation and how to apply it for surgeons, and how you even in Egypt or anywhere in the world can start using it, adapting it to your everyday practice. And then it will be open for discussions. So my journey started in Cairo to Ara, where I am now. So the 21 years, finished first 4 years of medical school. Then I went for 1 year to Charité, Berlin, to learn German and do my Doktorarbeit or doctor thesis. After that, went back to Egypt, finished the last 2 years of university, and went for internship or MTS in Switzerland. Then started my residency in Aarau, where Dr. Niklas Renner was the head of the department. He is the previous president of the AO Foundation. So I had the pleasure to work as his resident and publish a paper with him about the fracture of neck of femur. Then I did the AO Foundation Fellowship, AOCID Fellowship for Clinical Research. Then moved to Solothurn, which is also not far from here. Switzerland, the distances are acceptable. Half an hour with the train, you can be in multiple cities. Then I went for my trauma fellowship to Brazil. After that, went back to Belgrade with Professor Christian Gerber, where I started my shoulder and elbow career in 2013. After finishing my residency, I moved to Australia for 1.5 years. So I was doing elective reconstructive surgery for 1 year in Sydney and 6 months in Brisbane. After that, I was in Basel, as you mentioned, for 3 years as a consultant, and now back to Aarau, Rotrest, where I live and work now. So lots of fellowships, lots of great experiences. And then for the shoulder and elbow, also I traveled a lot to visit with people which I heard about, wanted to go to the Mayo Clinic, Harvard, visit Professor Bassem Al-Hassan, GB Warner, everywhere where I could find science and teaching and learning, I went to visit. So my history with books, actually it is my 3rd book now. The first book was in 2018, which is actually about how to get to Australia. So roadmap to Australian fellowships. If anybody is interested, you can access the website myfellowship.com and you will get a free copy of this book. So for anybody who wants to go fellowship abroad, there are a lot of paperwork to do, and this is a guide which takes you step by step for what paperwork you need to do. Then in 2019, I published the 2nd book, which was The Swiss-Made Egyptian, and it was very successful, become Amazon International Bestseller. And it is a guide from medical student to fellowship trained consultant, which take you through every step from being a student till reaching a fellowship trained consultant, with all tips and tricks what you need to take on your way. And now moving to the private practice and dedicating my time to shoulder surgery. So I just released the third book, which is called The 8 Most Common Causes of Shoulder Pain. So why a book? Because I find all of the publications we do and the research, I cannot give actually to any of my patients. So it is hard for them to read and understand. And at the end of the day, we explain the disease, we explain the problem to the patients, but the decision lies in the hands of the patient. So that's why they have to decide. So we try to empower them to have and take an informed decision. And this is what also got published in the newspaper last Saturday, where they were reporting about about me, who is not native German speaker and still took the time to write a book in German and inform the patient about shoulder diseases and how they can make a decision. So what is actually the concept of patient-centered shoulder surgery? What we try to do is get all of the stakeholders together. We put patient satisfaction as goal for all of us. And then if you look at the history, before in the early times when we used to do research, we used always to write, okay, range of movement, and then the strength and all of the objective values and scores we could do. And now with the PROMs or patient-related outcome measurements, the scale of research moved into another direction, which is more about patient-related outcome scores. What does the patient think, and not what we as surgeons think? So one of these issues is that what we found out through our research, that actually the outcome is not only dependent on the surgery or the surgeon. Patient is not only satisfied when he had a good surgery, but patient is satisfied due to different factors. So all what we do as surgeons, we try to optimize ourselves. We try to visit a lot of seminars, webinars, conferences, get our training, get everything done. And then end of the day, it's not the only factor which makes the patient satisfied. That's why we need to broaden our vision and go through the other concepts and factors which can influence that patient satisfaction. So I would like to take you through the book. So that's a live demonstration. So I will stop sharing the screen for a second, and then I will share another screen so that we can go through it. Yeah, so you can see it. When we go down through the book, it is done in 2 parts. First part, where you go, all of these shortcuts and short terms which we use in everyday activity and patients are not aware of. So we did put them here together so that they can find them easy. Then we go about general introduction about importance of mentors. Why are mentors important for us? Then it's diagnosis part is very important. How to get to the correct diagnosis, because this is a milestone in getting to the correct treatment, and the start of any algorithm starts by the correct diagnosis. Then comes the decision, should we operate or not operate? Then we go through the anatomy, different diseases, the most common for shoulder symptoms. It is more over the elective surgery. So trauma is not included in this book, this more elective surgery, all of the different diseases. And then we take step by step, okay, what are the factors and how we can deal with them and improve the patient satisfaction. So the first part is just go quickly through it. That's Professor Müller from Basel, where I worked with him for the last 3 years. He wrote a very nice foreword for the book. Then we know Adel Abdel-Latif. He's also radiologist in Switzerland, who his dad is also Egyptian. He's working in Switzerland and in Dubai. Also write the second foreword. That's a small introduction about the importance of mentors and how can they help you to lever your career, where you can learn from them in different continents, in different surgeries, which also help you develop your skills. This is the concept of the second book, The Swiss Made Egyptian, which is a medical career success path. So you start with the medical student, and here we should take them seriously, because all of those who are students today, in 10 years, they are specialists. In 15 years, they are assistant professors. In 20 years, they are professors. So we take them from the early days and start to think about, okay, who has a potential to develop himself further. Then they go through the internship, where they learn a little bit of, what of the theories they did all of the days before. They start to transmit it into practical. Then they go through the residence program. And then one of the very common in USA, Australia, Canada is the fellowship program, which is subspecialty. So when you finish your training, after, in Switzerland, for instance, it's 6 years of orthopedic surgery. After you finish this, you are still general orthopedic surgeon. So to become a shoulder, elbow, or spine, or knee, you do still need further training, and that's where you do a fellowship. And you go abroad for 1 year or half a year or 1.5 years, like I did, or sometimes you go for 2 years. Part of it can be research, part of it clinical or clinical, depending on the setup. When you come back as a fellowship trained consultant, we say there is a 3 T's, which is treat your patient, teach the students, and train other colleagues, from residents, from fellows, and other specialists. So that is the process of giving back after you have learned and went through all of that training. So that's about mentors. This is a German version. There is an English version, which coming up beginning of next year, hopefully, when I am done with it. So this is an important part, which is about the diagnosis. Some people, for instance, they see a patient and they say, okay, we just need the MRI. But then you see an MRI, rotator cuff tear, which is big, retracted, and then patient is still moving and working and doing everyday activity. And then you see one with a small tear and has pain, cannot sleep in the night, and needs an operation. So this is to elaborate that we don't treat pictures or MRIs or X-rays. We treat patients, and it should be adapted according to them. So, this is what usually happens in Switzerland. We have GP practice. So every patient has a general practitioner who knows him, and he goes to him regularly. If something happens, they start treating that patient, give medication, take to the physiotherapy, then they go back. And if there's something which doesn't work or doesn't get better, then they do further diagnostic and send to specialist. There is also a shortcut or rapid diagnosis, I call it. Instead of rapid recovery concept, there's a rapid diagnosis concept, which makes a house R as a GP has something like red flags, and he send the patient quickly when he sees this is traumatic. It is a patient who has a lot of pain, loss of strength, so that they are aware that it doesn't need to go for 2 or 3 months, but we can reduce it to 2 or 3 weeks. That's all of the different non-operative therapies which we use in our treatment. We have shockwave, PRP, plasma injections. We have hyaluronic acid. There are different things which we use as well, other than operating and physiotherapy. So anatomy, we decided to make it as simple as possible for patients, for their understanding, with very simple language, nothing Latin, nothing scientific for them, just the German translation of the medical expressions, so that they can relate to it and understand it. And then we go through the different structures. One of the decisions we took is to make it as simple as possible. So it's all hand-drawn figures from an illustrator, and the graphic designer drew all of that per hand, so that it's easy for patient to understand and relate to. And then you see, okay, that's impingement, for instance. We go through different diseases, starting with rotator cuff. Okay, here's a tear, and then we fix it as simple as possible to make it easy, understandable for the patients to read and go through. So we'll go through the different diseases. We'll jump this part. This is for you, probably very, you know it very well. This is one of the curves which we explain for the patient, frozen shoulder, how it starts with pain at first, and then the stiffness comes back during the first phase, inflammatory phase, then it starts to be stiff during the stiffness phase, and pain gets better. And then at the end, the stiffness goes away, and then in the route of 12 to 24 months. So just some illustrations to make it easy for patient. At the end of every chapter, there is a summary of post-operative treatment. How long does the operation take? How many days they stay in the hospital? When to start which sport? What is the physiotherapy protocol? What they have to do? So it's all summarized after each chapter. And that's a part where we can think about, okay, now we have a patient who is a bit informed, and that would help at one factor to get them happy. Then we move. Important is to tell them that they also have an important role. Some patient has the feeling they come to the doctor and they give him the problem and say, okay, we are away, and that's now doctor's problem. So we try to tell him, no, it is still your problem, and you have to work on it as well, and do the physiotherapy, do the exercises, and come to the regular visits. For the GPs, it's important to have a good relation with the GPs, so that if there any complication happen, any questions that they have, they send it back to you or ask you, and there is an open way of communication, which increases the efficiency of the system. Then there's surgeon factor, which is important that you get the training, you try to perform the most possible quality, use the most possible technologies. One of them, as I said, is the mixed reality, fellowship training, subspecialty, which help the more specific you are and the more concentrated on which specialty you do, the higher the number of cases you do, the more experience you get with time. Important part of it also is the training of the OR team, where they help you in the operating room. And this influences also your concentration during the operation, the all of the steps, that they go smoothly without any interruptions, lots of stuff. So what we use, something called the SPI. SPI is a program which we can put all of the steps of the operation digital, and it is on the screen. So it's like a PowerPoint for the scrub nurse, and she has a pedal with her foot where she can always press to the front and to the back, and through that she can see what is the next step. Also for the fellow, it's important to know, okay, what's the next step, and through that they can go forward and see, okay, now I have to prepare this and that. So they are a step before you, and while you are in this step, they know what's the following step already is gonna come. This helps in the training of fellows and residents and students, and they can also export this as a PDF to learn the operation steps before even coming into the operating theater. Then comes the part about the implants. So we have a very good relation with the industry, with the company. We're involved in Exatech for the navigation company. I'm on the advisory board for Johnson & Johnson, MyTech for all of the anchors and development of arthroscopic pumps. It's important for them to get feedbacks from doctors to know, okay, which products are working well, what are the problems, how to solve it, how to make it better. So a good relation with the implant or with the industry is important to get better products to the market and solve our problems with their know-how and engineering. So also during the hospital, when patients are inpatient, it's important that the hospital staff knows about disease. What are we gonna do? What are the guidelines? We have all of the guidelines for every operation. We are ISO certified, and to be ISO certified, you need to put all of the SOPs or standard operating protocols. So every operation which I do, there is a protocol, what to do in the preoperative phase, what to do on the day of the surgery, what to do after the surgery, what painkillers are used, what physiotherapy, everything with the nurses need. It is already on their system, which they have access to it 24 hours, which save a lot of hassle and calls and going around. Every day we go to the visit in the early morning, we see patient for 5 minutes, 10 minutes, and then they have everything documented without having to ask us again. If any complication happens or something, of course, they will contact us. That's important for them for being aware about the situation. Hospital kitchen is also an important part, maybe depending on how big the operation, if there is a revision surgery, if there is a bleeding, if there is a nutritional problem that also influences the wound healing. That way we always see what is the situation. Sometimes we have to order the blood albumin to check if it's enough, if we need to do any special nutrition, to take care about his nutrition or her nutrition. Also pre-operatively for abdominal surgery, for instance, or bariatric surgery, they give special vitamins even before the operation to get them ready. One also very important factor for us is a collaboration with the physiotherapist. So around us, all of the centers, we know which patient goes to which physiotherapist. They get also letters from every visit. When the patients come to me for a follow-up, they get a letter, and this letter goes back to the physiotherapist, goes back to the GP, goes to the patient himself and the insurance. Then part is the infrastructure, which is very important. Our operating theater is a very digitalized one, where we can use all of the infrastructure integrated together. We have screen, we can do live surgery, we have cameras inside it. We have 6 screens where we can put our x-rays up, we can put everything digitally, and it's available for everybody in the operating theater to see it independent on where he sits or stays. Also, if the assistant is on one side, he has a screen for him as well, so he sees what I'm doing in the arthroscopy. Even if I'm on the other side, we can both simultaneously look into different screens. Insurance is an important factor in Switzerland, Europe, and US, because most of the patients are insured, and for you to do an operation, they have to give a green light and say, okay, you're accepted to do this operation. That's why documentation plays a very important role, and every patient we see, we need to document this. And then I will take you through this process afterward. Then through the so this is a doctor, that's the insurance, and that's the patient. So actually patient don't pay doctors in Switzerland. Patient pays the insurance pays the doctor. So when we bill, we don't bill patients, we bill insurance. And patient don't pay for the cost of treatment, they pay premium for the insurance every month. And no matter what they need from the healthcare system, it is covered through their insurance. Administration and secretary is a also very growing part because of all of the preparation before the clinics, after the clinics, during the hospital, inpatient, going back home, coming back, calling for registration, collecting x-rays, MRI for every patient. So there's a big load of administration, which is accompanied with every patient. And these secretaries also has to be aware of the different diseases and different algorithms which we have, so that to be able to give us a little bit more time for patient care rather than being there for the administration. So that's actually the main concept of the book and how it could help us as surgeons and the other surgeons as well to get the whole concept done. And once you have all of these 11 factors communicating together, you have a higher chance of better outcome and satisfaction of the patient. We'll go to the presentation again and we'll continue. When patient comes for history taking, there is also standard history taking form, which are the patient-related outcome scores. So you have the American shoulder and elbow score, that's at the bottom. Then you have the VAS or visual analog score from 0 to 10. Then you have the subjective shoulder value, any medication, painkillers with patient needs. Dexterity, is he right-handed, left-handed? Then he can draw here where is actually the pain, and information about sport, work, anything related to his sport as well. This is important because this is important information which we collect pre-operatively, and then with each follow-up visit as well. And this is all entered in a data bank, and then how we can do outcome-related research from this data. So we collect all of the information prospectively and not retrospectively. For the examination as well, we always use a constant score. So it is standardized, and every time we can compare pre-operative, post-operative, 1.5 months, 3 months, or 1 or 2 years post-operatively. Now we move to the other part of the presentation, which is more about intelligent automation. So what is intelligent automation? We hear a lot about artificial intelligence. We hear a lot about deep learning, machine learning, all of that nice terms. But then it comes to the bottom line. If you start using only one part of it and not the other one, and not connecting them together, you still didn't get the most out of the technology. So if you think about intelligent automation, it is collecting all of the available technologies together into one pool, which help you accelerate and have more efficiency. We are busy, we have a lot of things to do, we have to be here, we have to be there, sometimes 3 places at the same time. And to easier our life, we can use a lot of technologies and techniques which help us reduce the workload on us and on our administration. So this is a concept which was introduced in 2017, actually from IT companies. Then it got adopted by many multinationals like Johnson & Johnson, Vodafone also have things like that. Chatbots, when you get into any website and bots are trying to connect with you, or when you give a call to any call center, and then it comes with a bot is at first connecting to you and asking questions. And this is how they try to make more efficient. Also for financing, accounting, it is important part, human resources, technology, supply chains. Also when you use medication, and when one medication is done or almost done, then you can automatically reorder it without having humans involved. This allows you to have minimized risks that a patient is here, have an operation, and we don't have the correct medication, or it is falling. So how we can use this in our everyday activity? I will take you through some examples, life examples. So I will share the screen again. If you have any questions so far?
No, sir, no questions till now.
Okay. So once you go, for instance, you look at it from the patient point of view. Patient is looking for shoulder surgeon. So he goes online and write shoulder chirurg. This is shoulder surgeon in German, and he goes Google, and then he finds, okay, there is a website, there are some reviews on it. He can click on it, check the reviews, see, okay, a nice guy, well talented, what the patient says. So it's important for the patient to know, okay, before they go to the doctors, they do a lot of research today. So once they see that and they said, okay, sounds interesting, let me go to the website. Then they click into the website, and that's where you can start the automation of managing patients. So if they are here, they can, if it's German, they can use German. If it's English, if it's Arabic, they can use the language they want. Let's do English. Then, okay, they look at it, to the surgeon, some patient information here, information for the general practitioners, information about the team who is all involved, fellowship training of the doctor, media, where has it all been mentioned, book, and then they can contact us. If they want to make an appointment, they can call, they can send an email, or they can use already our automatic booking system, which they can click here. Then they can choose, okay, when is the working hours, where is it available? Then, okay, he works in Arau, he works in Rotris, 2 places. I try to book an appointment in Arau. Then they click, They see, yes, I have been there before, just a follow-up, and then they see where are the available appointments. And then say, okay, I will go here at that time, and then they can book the appointment. This appointment goes directly to our automated calendar, and every patient gets an automatic reminder for the appointment and tell him, okay, we are here, you are supposed to come to that appointment, and he can choose to get an SMS or an email without me or my team getting involved. So it's all automated. And that's one of the parts where they can choose from. If they go down, and then they can see videos introducing the team, our concept, how we treat patients, primary, secondary opinion. Then they have also a link to our YouTube channels. They can go watch videos about surgeries, about the new technology, navigation, concepts. They can review the reviews also on the website, contact us, all of the collaborations, hospitals and institute memberships we are working with. They can also, if they are in social media, they can review the social media part here. So that's the first step and first contact with us. Now there are patients who say like, okay, I am going to the patient, but I'm going to the doctor, but I have already some x-rays or I have an MRI. How can I do this? They can go for patients, and then they find the link, share pictures with us. They can upload directly their MRI or x-rays, just put their name, email, press upload, and then it all comes to my cloud system where I have all of the patient data. So when I log in, I can go to my cloud platform. I see my images. This is accessible anywhere in the world. Doesn't matter where I operate or where I go. I see all of my patients, x-rays, MRIs. You can always share which patient, and then you see the related pictures, the related x-rays. You can get in, you can walk around, see any images you want. You can make any drawing on it. You can measure angles. You can measure length. You can share it also with other doctors. If I want to share this with another doctor, so I put his email address, I can share it with anybody for second opinion. So we have an environment which can help the patient. So this is the pre-consultation phase. What happens when the patient arrives and he is already with us? So we have another system. I will show you. This is called PIS, or Patient Information System. It's all digital. When patient come to us, you can put diagnosis. If he did already an online booking, then you see it in our calendar. So I have it in my calendar. I see it. If can show you here, I see all of the calendars. Okay, which patient coming and what time, where did he book, what is the problem? It's all already done into the system. When they finish this information on the website, it gets automatically transferred to my system. Then you go into the patient. As you said, we have to document everything. So you document diagnosis, other related diagnosis, then you take history, then you get into, okay, what did you find out? As you see, there is a lot of things to document, and time is limited. So what we do is use an electronic artificial intelligence system with deep learning, which means I can dictate the text. For instance, Herr Ali berichtet über Schmerzen und Empfindlichkeit über die Schulter. Punkt. And the system writes what I sent. I check it and I say send, and then we have the text here. This saves us a lot of time, and you don't need an extra secretary which goes and write all of the text which you dictate. So this is also one of the steps which saves a lot of time. After you did the examination and you documented everything, it is all insurance related. So there is a predefined parameters. So you say, okay, I have seen the patient, and then you can choose any patient, and then you go and then you can say, okay, I have seen the patient, I spent 10 minutes, 20 minutes, whatever time. You can here just click 5 minutes, 10 minutes, whatever you did with the patient. I did an injection, I did an ultrasound, I just examined the patient, I just talked to him, telephone, email, whatever you did, you can just click it here, and then it is in your system, which gets the billing automated. So here you can go to the booking, and then you can export all of the bills, and then it goes automatically to your company with the insurance company. Once the insurance company paid the money, then you can download a bank statement from your online banking, and then come here and say, okay, I will upload it to the system here. You can upload the file, and it double checks, okay, which bills has been paid, which bills has not been paid, which insurance is still waiting for you to have a reply. So that's how you can have one environment which help you with all of the process dealing with patients, and saves a lot of time and personnel who would have to do this manually. Any questions so far?
Yes, we have one question. Thank you so much for your very valuable information. What's the indication of
Indication of local injections, it depends on the condition. So as we said, the first step is to have a diagnosis. So when patient comes, he gives a history, I examine him, then I do the ultrasound to check tendons, ligaments, and so we have X-ray to see if there is any calcification, arthritis, displacement, any bony injury. Then we have the ultrasound to check for any soft tissue conditions, the rotator cuff tears, biceps injuries. We have this, and you have the examination and the history. After collecting all of this data, then you have a diagnosis by 80 to 90% of the cases, and then you can do the injections. So depend on the disease. If you have bursitis, for instance, you can inject cortisone. If you have a tendinopathy, which is not related to a cuff tear, we can inject PRP or platelet-rich plasma. If we have beginning the arthritis, you can inject hyaluronic acid. There is also like 3 places in the shoulder which we inject. I do it all ultrasound guided. So AC joint or glenohumeral joint or subacromial space. Subacromial space is for bursitis, or you can inject into the tendon, but then you're only allowed to inject platelet-rich plasma. Otherwise, you're not supposed to inject cortisone inside a tendon because it weakens the tendon and increases the risk of re-rupture. Any further questions?
Yes, sir. We have another question. What's the role of hyaluronic acid in shoulder diseases?
It is similar to knee diseases or hip diseases in the early stage of arthritis, where you don't have a fulminant one with a lot of exostosis, and or people who don't want to get operated upon and you want to try a conservative treatment, we can inject hyaluronic acid, which help with the lubrication of the joint.
Thank you, sir.
You're welcome. So let's move forward, not to take a lot of your time. We go back to the presentation. So now we introduced the artificial intelligence automation. Now we go to the part, if it works, with mixed reality. So mixed reality itself, it is the merging of real and virtual worlds to produce a new environment where you can simultaneously see a hologram, which is not actually existed, it's only virtual. And you can still manipulate it and move it around and put it into the different positions which you need. In the early days, before we used to use this technology, we had the 3D printer. So we could print the scapula as a 3D, and then you can see, you can have a patient-specific instrumentation which help you, guide you through putting where the guide wire should be, and you can compare the 3D print to the real patient. Problem with it is it takes time, it's costly. You have to have a 3D printer, then you have to sterilize it, then you need a third hand to hold it, because if you are working on the shoulder and drilling, and then still you have to hold the 3D diagram in the hand, it's not possible, so you always need an assistant to hold. And the fun part or the advantage of using HoloLens and mixed reality is you skip all of these steps. So now we come to part of live demonstration of the HoloLens. I can show you. HoloLens is like a headset. It's about 440 grams. It has a hard disk of 50 gigabyte inside it. It has different processors with cameras over here. You can see different multiple cameras, so you can do live surgeries using the HoloLens itself. Then you can just put it on your head. You start it, and once you start it, you start seeing a screen like a mobile phone. So I will try to get you to see what I see. Let's see if this is gonna work. So I will connect. So what you need to do is to actually go to your computer. You can start a preview program on your computer. Then you can start capturing what you see on your screen. Now I will try to share this screen with you. Okay, so you see what I see? So now we have the shoulder in front of me, a lot of different so that's the scapula itself on one part, then a scapula with the base plate on it. Then we have the scapula with a K-wire inserted. Is it clear for you? You see what I am seeing?
Yes, sir. We can see it quite clear.
Awesome. Then you can turn it around, whatever direction you need. And you can manipulate it while you are sterile. You're not touching anything, so you have all of your sterility untouched and still you can use it. You can hands-free manipulate it as well. So I can just put it here and move it far away from me. I can get it back to me, close. I can turn it around even without touching it. Can use another one, put it beside it. And also depending on which apps you use, it is like a smartphone. So you can open it, have different apps in front of you. You have Microsoft Store with the different apps inside it. You can choose whatever app you want. You can open your MRI scans. You can open 3D viewer to watch other diagrams, for instance. So you prepare the models in advance, and then you can open them inside the operating theater and can manipulate any of them. So here we have, for instance, the base plate. You can view the base plate which you're gonna implant. Can remove the side of it. So this is a part with the live demonstration, and I will stop sharing the screen again. Then I will take you back to the presentation. After going through the HoloLens, now we will show you two cases of real-life surgeries, how you can use that technology which we have seen now relating to patient and treating them. So I will leave you with the
This is Mohy Taha. I'm fellowship trained shoulder and elbow surgeon from Switzerland. Mixed reality is the merging of real and virtual worlds to produce new environments and visualization. In the following two cases, I will be showing how we can use this modern technology for preoperative planning of joint replacement and how to use it intraoperatively. Today, I'm presenting a case of an 83-year-old female suffering from pain and limitation of range of movement for the past 6 years. Constant score is 21. Subjective shoulder value 30. Here in the CT, you see the cranial migration and erosion of the glenoid. On the axial views, you can see the retroversion and bone defect posteriorly, which we measured to be 13 millimeter. The 3D planning shows the defect cranially and posteriorly as well as inferiorly. Dr. Gabato from Brazil helped out creating the augmented reality reconstruction of the CT so that we can take a deeper look into the case. Moreover, he was kind enough to plan the bone graft for us. Dr. Thieringer helped us by printing the scapula 3D so we can take us into the operating theater. Now you see there is a big bony defect, so I thought to solve this problem I could use navigation. So I went and visited Dr. Drum in Germany, who introduced me to the system how to plan the 3D planning using the Exatech software. And he showed me two of the cases he done at that day. The installation is simple by fixing a bar to the operating table and then covering the GPS with stripe drapes. After that, I decided to try this system in our case, and the Exatech team came over to give a workshop to our crew. How do I know it's that? What is that?
So here we use the mixed reality for the preoperative planning and navigation for the real execution of the plan we did before. It's acquisition, the coracoid, and then we go to the undersurface of the coracoid. You can hear the system gives you feedback. I will show on the screen where you have to go with your navigation pen. Then go through the glenoid. There are 4 points which you need to check: inferior, superior, anterior, and posterior. While you are drilling, you can see in real time how far and in which direction you are Very good. When you place and insert the glenoid base plate, then you can fix the screws also under vision.
This is the intraoperative X-ray, and here you see the postoperative X-ray. Thanks for watching. I'd like to present a case of a 48-year-old female patient with history of 2 failed cuff surgeries. Now pain and limited range of movement. Subscapularis is gone. If you look at the cartilage from the arthroscopy, it's also gone. So we decided to convert her to a reverse. Here we could use mixed reality to view the current situation with pyrocarbon hemiarthroplasty. From every side, you turn it around. Here we view the preoperative planning, also using HoloLens and Mesh app to turn it around. Here you see some artifacts which are produced during the segmentation due to the hemiarthroplasty within the CT. Here we're using another app to view a 3D hologram, subtracting the glenoid and concentrating on the K-wire. You can also turn it in every direction. Now getting ready for the operation, wearing the HoloLens. This is a deltopectoral approach, going through the previous scar, then performing the external release or subdeltoidal release.
There's a camera from
now we go through the scar of the subscapularis. We couldn't really find a tendon, but here you see the pyrocarbon hemiarthroplasty, so you see the head of it. After peeling the scar, you have a good view on the head. Now release of the upper border of the big major. Then getting the fork, you can use it to remove the head, tapping with a mallet, and we get the head relatively easily. After that, we expose the glenoid. We'll be able to have a good view. After that, we perform the internal release and removal of soft tissue, including the rest of the labrum. As soon as we have the glenoid ready, now we open the Cyclops app and view our planning. Here you can turn it in every direction and put it beside the patient so you can view the direction. You can also change the color of your hologram and choose a suitable color. While inserting the K-wire, you can still view the hologram simultaneously. The hologram could be adjusted to the anatomy of the patient. We were able to maintain the stem and convert it to reverse. This is the intraoperative and postoperative results. Thank you for watching.
So these are like the 2 cases we had. I would like at the end to thank you and welcome you also to visit us in Switzerland. We have a beautiful restaurant, Egyptian, called Simsim. We had guests from all over the world. This is Alex Lederman from Geneva. This is GB Warner, the head of shoulder and elbow department in Harvard, Boston. This is Bassem El Hassan from
with you,
the Mayo
sir. Yeah.
Clinic. This is Joe, the head of the Shoulder and Elbow Society in Taiwan. This is Florian, was from Switzerland, going to GB Warner to be a fellow, and that was a fellow visiting us here in Switzerland. We also had Egyptians visiting us, Professor Ashraf Muharram, who came to us, and multiple Egyptian fellows and Saudi Arabia and everywhere from all over the place. So next time we would like to welcome you, Professor Muhammad, here in Simsim restaurant, inshallah.
Inshallah, in Simsim. I was in Zurich. I was in Zurich about 5 years ago, and in Geneva about 2 years ago.
Yeah, so Simsim is in Zurich.
Yeah. Thank you so much. يعني احنا مش عارفين نقول لحضرتك ايه دكتور محي. يعني انت حضرتك اسعدتنا وامتعتنا بصراحه. thank you so much for being with us tonight.
You're welcome.
وان شاء الله نشوف حضرتك على خير في مصر دكتور محي. جزاك الله كل خير، وان شاء الله نسعد بلقاء حضرتك ورؤيه حضرتك دكتور محي بيه. Thank you so much to the eminent Dr. Mohy Taha from Zurich, from Switzerland. I hope to see you in Egypt. Thank you so much. Hoping to see you very soon, inshallah. شكرا جزيلا. تصبحوا على خير يا فندم. شكرا جزيلا دكتور محي بيه. تصبحوا على خير يا فندم. شكرا يا فندم. سلام عليكم.